Hey everyone, Prof G here, and today we're going to be going over the physical exam. And I know that y'all have a huge practical examination coming up at the end of the semester, and I want to make sure that I guide you through week by week the different pages of the rubric and how to best approach these exams and give you some tips and tricks along the way. So today I wanted to do kind of a quick overview of the physical exam and the approach to the patient. And then I want to tackle the first page of the rubric. So let's get started. All right, so the approach to the practical examination. So you always want to treat the patient the way you want to be treated and respect them and talk to them just like as if you were talking to a real patient in a real life scenario. I know that a practical exam is just about as far off from real life as you can get, but do your best to try to mimic those same bedside manner characteristics that you want to emulate when you are out in the clinics. Verbalizing what you're doing is going to be very important for you and your lab instructor. So the items that you can't see, it's going to be hard for us to know that you know what you're doing, because right now this is a demonstration of your skills and going through the motions, and we can't read your mind. So we have created a verbalization key, which I will show you here shortly, to help guide you through what we would like for you to say out loud to us as your instructor and out loud to your patients. That being said, we want to try to keep things as natural as possible. There's nothing like, doing an entire 40-minute practical examination of head to toe physical. And then you get out in the clinic and you're sound like a little robot saying, oh, this and this and this. You want to keep it as natural as possible, close to real life, like you're actually talking to a patient. So I'll show you some tips and tricks along the way to help you so that when you are verbalizing these things to your instructor, you're actually verbalizing them to your patient so that it feels more natural. Now, for the exam, we have 250 plus items on your patient encounter rubric. This is más o menos, but that's a lot of items on the list. So you have a lot thinking, okay, cool, I can miss, I don't know how many, and I'll still get an 80%. Well, it's not by percentage on the grade. You must score at least an 80 to pass this practical examination, which means you can only miss 20 points. You cannot miss more than that, or else you'll have to repeat the examination. You'll want to submit all of your weekly videos so that your instructor can go through them and give you some critiques and give you some feedback. And if you submit all of your weekly videos, you will get 3 additional points onto the practical. So you must score above an 80 to use these 3 points, and the max score is 100, so you can't get 103. There's also no partial credit. So if you only submit a couple of the videos, you can't get partial credit on this extra credit. Now, for the practical, for grading purposes, you'll get half a point off if you do the exam, but you use improper technique. And if you've missed the item altogether, that will be a point off per item. You also tend not to have an extra table or anything when taking a blood pressure. So I will kind of show you how I like to cradle the arm for the blood pressure. You also need to make sure to wear a watch with a second counter on it so that when you do the vital signs, you're able to calculate the pulse and the respirations. All right. What I will show you here as we go through from week to week is how to set up your practical table. So you will get one little table where you'll be able to set down all of your equipment, and I have a recommended way to set that up. So as we go through from week to week, I'll kind of show you how you'll want to set that table up. You want to set it up the same way every time so you'll know exactly where to grab your equipment, and also you set it up in a way so that when you grab your equipment, it'll help remind you about what the next thing you have to do is, because everybody knows when we get into a practical situation and we're being graded on an examination, we tend to get very, very nervous. It's natural as being a human being. So my job and my goal is to get you prepared so well that the nerves don't override your skill and your abilities. All right, that being said, let's take a quick peek at the rubric and page 1 of the rubric, and then we'll get started on the dissection of that. All right, so here we have the patient encounter rubric, a practical rubric, and today we're going to be going over just the first page of the rubric. You can see the grading up here. This is exactly what I just went through, and here's the spot where your instructor will put whether or not you submitted your videos. The next thing is the verbalization key. So the yellow are going to be instructions that we give our patients. Very, very important to give clear instructions so that they know what your expectation is. One key tip for this is if you work only with your friends that are in PA school with you, you're going to find that they already know what the instructions are. They already know how to perform these exams. So even if your instructions are not clear, they're going to know what you're talking about. My advice to you is do some of your skills or practice some of your skills on people or family members that do not know about the rubric so that you can make sure that your instructions are clear. The green are going to be inspection items, so things you're going to want to verbalize to your instructor that you are inspecting. And then number 3 are some things like results or things that we get out of the examination that we need to verbalize. Okay. So that said, quickly looking over this, today we're going to be talking about the general survey, which is the basic overview of how the patient appears. Then we're going to talk about vital signs, the basic vital signs and how to take them. And last but not least, we're going to talk about the skin exam. I'm going to go next up and talk step by step through the general survey, and I have a little cheat sheet that I'm going to walk you through. It's going to help you understand what each of these items mean and how to assess them. Before we go into that, I do want to talk about the introduction. So anytime you have an encounter with a patient, one of the first things you should do is introduce yourself to the patient. And it's something as simple as, hi, I am so-and-so. I am a physician assistant student, and I will be conducting your physical exam today. Is that all right with you? And they say, yes, great. There's your introduction and your consent. Usually here I like to interject, if you could please verify your name and date of birth while I wash my hands. I will use Germex to wash my hands while the patient tells me their name and their date of birth. What I like to do, get in that habit of doing, is pretty much every OSCE you will have from here on is going to require you to ask that of your patient. And it's just good to get in a habit of making sure you're seeing the right person. All right, next up, we're going to go into the general survey. So let's hop over to the cheat sheet for that one. All right, here we go. So we already introduced ourselves, we already obtained consent, and we washed our hands. Next, we're going to do a survey of when the patient, of what the patient looks like. And for this practical, we're starting at the physical exam, but for any encounter you ever have with your patient, you're going to already have been talking to them for some period of time before you come to your physical exam. You're going to have taken a history and talked about why they're there. And so you're already assessing this from the minute you walk into the patient's room. And your power of observation is something that you can really hone in on to try to assess the patient's overall well-being. And during our history and throughout the visit, we're going to continue assessing this as we move forward. So the first thing on our list is a mental status. Now, this is the one thing in the general survey that we actually have to ask our patient because we need to make sure that they are alert and oriented. So we've already asked them if they are alert oriented to person. Person is who they are. All right, so we've already had the patient state their full name earlier. If for some reason you forgot or didn't ask them what their name was when you entered the room, you would need to ask them at this point. So it's something as simple as asking, can you tell me your full name? Yes, great, they give you your full name. Next, you're going to move to place. Place is where they are currently. So can you tell me where you're at currently? Yes, I'm here. If they aren't able to tell you, I always like to start as specific as possible and kind of backtrack. Well, if you don't know what the building is, can you tell me where you are, what campus you're on, or what hospital system you're in? No, can you tell me what type of place you're in? A hospital, a school, things like that. And kind of backtrack from there. Next, you're going to want to assess for time. So that's what time it is or what date it is, or you can ask the date. I think that's the easiest way to start. Can you tell me what today's date is? And if they can't, then you can scale back to the month. What month are we in? You can ask them, what holidays do we celebrate at this time of year? You could ask them what season we're in, or even just the year in general, and see how well they do with that. There is another orientation, and that is the situation. You can ask them why they're there in the clinic or in the ER. But by this time in the encounter, you probably know if the patient is oriented to situation. So for our practical, we usually stick with person, place, and time. And after we assess that and ask those questions, we can say that the patient is alert and oriented ×3 or ×4 if you assessed for situation. Some other options that we would have when documenting if our patient is not alert and oriented, we could change it to lethargic or somnolent. Those are some other options that we could use. For our practical, everything will be normal, which is good. All right, next we're going to move on to affect, mood, and manner. So the affect is the patient's visible reaction and kind of the way that the person is displaying towards events. So this can be described in many, many ways, but some of the ways I've seen it is normal, constricted, appropriate to context, flat, or shallow. And after you assess that, or as you've been talking to the patient, you've been assessing it, you can then document that it's appropriate, restricted, blunted, bright, flat, labile. Really, there's a lot of different ways that you can document affect. The mood is kind of like the underlying feeling or state, kind of like the mood, the vibe within the room and the way the patient is feeling. And this is like anxious, depressed, euphoric, angry, irritable. It's kind of their mood, right? And people can go through mood swings, but how is their mood currently? And so these are just some examples of some of the things that we can document when we talk about the mood and how the patient is displaying. And in here, I have the suicidal ideation or homicidal. This is not always part of the mood, but if we notice that the patient is maybe anxious, depressed, or withdrawn, then we might ask them about this depending on what they're there for. For our examination, I'll tell you what we need to say in just a second. The manner is also kind of the way that they act overall. It's kind of their demeanor. Are they open? They're friendly? Are they expansive or irritable? And there's a whole bunch of different options that we could choose if we were actually documenting this on a patient. So after we assess that, this is all happening in real time. Definitely not going to have to do any of this on the practical exam. All we need to say is that the patient has a normal affect, mood, and manner. Or you can also say, I'm assessing the patient's affect, mood, and manner. And I like to say this is kind of like a timeout, where one of the only places in the practical exam where you're actually telling your preceptor or your grader exactly what you're assessing for in the general survey. So this is probably the most unnatural portion of the whole physical exam, because you are kind of doing a timeout and saying all these things about your patient who's sitting there in front of you. All right, so next up is the apparent state of health. So we're looking how they appear. Are they healthy, frail? Do they look acutely ill? Do they look toxic, dehydrated? There's a whole bunch of different things that we could document in this part, basically looking at their state of health. And so for our purposes, our practical is we're going to say patient appears to be in a normal state of health, or patient appears healthy. All right, next up, we're moving to level of consciousness. So we already kind of assessed this level of consciousness when we were asking them about their alertness and their orientation. So at this point, we can say that they are awake and alert, or lethargic, they're comatose. For our purposes, we can say the patient appears to be at a normal level of consciousness, or normal level of consciousness. Everything is going to be normal for this exam. Moving on, we're looking for signs or symptoms of distress. This can be either cardiac, respiratory, they can be invisible pain, they can be displaying some anxiety. So we can document it in all of these different ways here, the signs of distress. But for our purposes, we're going to say appears to be a normal level of consciousness with no signs of distress. Okay. Body habitus and posture. So with body habitus, we're looking for whether they are a normal weight, obese, overweight, thin, cachectic. For posture, we're looking at how they walk, how they hold themselves. If they hold themselves upright, they're slumped over, defeated, tense, relaxed. It's really kind of how they are positioning their body and their body language. So there's going to be different ways that we assess that. For this practical, we can say either assessing the patient's body habitus and posture, or you can say normal body habitus and posture. Just definitely don't make a mention if your stimulated patient is actually overweight or obese. We definitely don't want to call anybody out that's doing as their simulated patient. We don't want to make them feel uncomfortable. So for our exam, we're going to express that everything is normal. Next up is dress, grooming, and hygiene. So for dress, is basically how they're dressed. Are they dressed for the occasion? Is it hot outside and they're wearing a parka? Or is it appropriate their dress? Or maybe they're not dressed well, they're disheveled, or they're unkept. So we want to make note of that. We also want to look for grooming, whether they're well groomed, they have good hygiene. And the best way to look for that is just to kind of look them over. What are they wearing? Are they well dressed? Is their hair messed up? Have they taken a bath recently? Can you smell that? It's multifaceted. And the way that we can document it is here, different ways to document. But for our practical, again, it's going to be normal. So we can say, we're assessing for dress, grooming, and hygiene, or dress, grooming, and hygiene are appropriate or normal. And last up is speech. So you've noticed I've been talking here for a minute. I've got a little bit of pressured speech. I talk a little bit fast and naturally, and that's my normal pace. But you'll notice with your patient, their pace, the intensity, whether they're slurring their speech or if it feels kind of pressured, like they're trying to get it all out. And you can see here that there's tons and tons of different ways we can document the way the patient's speech is, the rate, the clarity, whether it's comprehensive, like whether they're comprehending. There's a whole bunch to it. But for our practical, we're going to say, normal coherent speech. All right. And so that sounded like a whole lot that we just went through. But for the purposes of our examination, we're basically going to spout off those different things. And I'll give you a demonstration here shortly.
Hi, my name is Christina. I'll be a physician assistant student taking care of you today. Is it all right if we proceed with the physical exam?
Yes.
All right, can you tell me your name and your date of birth?
Yes. Aisa Rodriguez, 0131, 2001.
All right, thanks. So let's start by talking about where we are right now. Can you tell me where you are?
Yes, at UTRGB.
All right, and can you tell me today's date?
Yes, February 13th, 2025.
Great, all right. So the patient is alert and oriented ×3. They have a normal affect, mood, and manner. They appear to be in a normal state of health. They are also conscious with no signs of distress. They have a normal body habitus and posture. They are appropriately dressed, and they have appropriate grooming and hygiene, and they have normal coherent speech.
All right, next up, we're going to look at the vital signs. So vital signs are vital, right? They are there for a reason. One of the first things that we look at before we even walk into our patient's room. I always look at the vital signs and the chief complaint, so I know exactly what I'm getting into. And you can't really fake vital signs. They're very objective. They're the first part of our physical exam, and I use them. If I notice that the patient's vital signs are off, it is cluing me in that I need to be a little more careful with this patient because something is happening. There is something going on here that I need to make sure to diagnose correctly. And for our practical purposes, we have to assess for the heart rate and rhythm, for the respiratory rate, and a blood pressure. So let's talk about heart rate first. What is a normal heart rate in an adult? Should be between about 50 and 90. Anything more than 100 is going to be abnormal. We're going to check the pulse on the radial portion. So the radial is on the thumb side of the wrist, and we're going to lay our index finger and third finger on the inside of the wrist here, and that's where we're going to check a pulse, right at the base of where the wrist meets the hand, and we're going to feel for the radial artery. Make sure that you can actually feel this. I know that for a lot of this practical examination, we might feel like we're kind of going through the motions or pretending to be a PA. But one thing I can really try to encourage you is to, if you can't feel or do something when you are in lab, ask your instructor to help you out. You definitely don't want to fake these things and never get the hang of them. So this is the time to learn. So you're going to palpate that pulse. General rule of thumb is to count it for 60 seconds, and you're going to be looking at your watch that has a second timer and count it for 60 seconds. Now, on your practical, no one's got time to count a pulse for 60 seconds. That's a valuable minute. So I have instructed my students to go ahead and count for at least 15 to 30 seconds. You can count for 30 seconds and multiply it by 2. And for the pulse, I'm allowing my students to count for 15 seconds and multiply it by 4. Please ask your lab instructor what they want from you so that you do this correctly. If it's irregular, or if it's not slow, if it's not steady, you might want to compare it with a different pulse. And you do have to compare the pulses bilaterally. So for that, you want to have the hands resting in the lap, and you want to take your two index and third fingers, and you want to palpate both wrists at the same time. And you want to do that for, it says for at least 30 seconds. I usually do it for about 10 to 15 seconds, making sure that they're equal bilaterally. When you're done with that, you're going to want to say the pulse number. If you don't want to say, let's say that your patient's pulse is really high because they're nervous because they're your simulated patient. If you don't want to say that they have a pulse of 140 and get them all nervous, you can say that the pulse is normal, or you can say that the pulse is, between 16 and 90. You can say a normal rate. And then you also want to document or verbalize that the rhythm is regular and that the pulses are equal bilaterally. Okay. Moving on to respiration rate. So the minute you start talking about breathing, you notice how you're breathing. So the last thing you want to do is clue your patient into the fact that you are counting their respirations, because it will alter the way that they are breathing. So what I like to do is incorporate this into taking the pulse. So I start with taking the pulse on one arm, and then I like to fold the arm at the elbow and lay it on their chest, me holding their wrist still. And I like to feel for the chest rise and fall at that time without telling them that I'm listening or feeling for their respirations. They still think I'm feeling for their pulse. And so as you're doing that, you're observing the rate of respiration. You're going to count that for at least 30 seconds and multiply it by 2. You're also looking for the pattern. Is it steady? Is it irregular? You're looking for the depth of breathing. Is it really taking really deep breaths or really shallow breaths? And the effort. Are they using accessory muscles? Are they having trouble breathing? And those are all things you are noticing as you're observing their respirations. So when you're doing that, you're counting the breaths. A normal breath is less than 20 in adults. You're going to count it for 30 seconds, like I mentioned, and multiply it by 2. And these are the other things you're looking for. You're looking for, are they breathing slow or fast, regular, irregular? Are they having different types of patterns of breathing? Are they shallow, gasping, normal, labored, using accessory muscles? And at the end of all that, you're going to mention the number of respirations you counted, and you're going to mention that there's normal rhythm, pattern, depth, and effort after you check for that. And the reason why I include depth and effort, as you notice they're not on that first page of the rubric, is that you will have to assess for that in the pulmonary exam. So you might as well mention it now and get it over with. As we go through the rubric, I will kind of clue you into when I tend to leave certain items out or in at those points. Like there's sometimes when I pull something from a different page onto this page, just because we want to try to do the most efficient exam possible. All right, moving on to blood pressure. For blood pressure, obviously we want our patient to avoid drinking caffeine or smoking within 30 minutes. They want them to be in a quiet place with their legs uncrossed. And we want to make sure that the blood pressure cuff size is appropriate for your patient's arm. Then you also want to make sure that you don't take too long to release the pump, so that the venous congestion doesn't build up and it doesn't alter the reading that you get. For blood pressure, technically, you should get 2 or more readings if you have a high reading at 2 different occasions to diagnose someone with high blood pressure. So normal blood pressure in an adult is going to be 120/80 or less. And then you can see here there's different stages for different elevations. We're not doing abnormals here, but I'm just mentioning it to you. So on your rubric, the first thing that you're going to do, it says here, is feel for a brachial pulse. I usually don't feel for the brachial pulse first. I usually do it right before I put my stethoscope down. But if you want to start there, you can feel for a brachial pulse. For me, the best way to palpate a brachial pulse is to find my biceps tendon and go just medial to that. And I use, again, the pads of my second and third finger to feel. And you have to push a little harder than you do for the radial pulse to feel it. And you're going to feel for that pulse. Next up, you're going to put the blood pressure cuff on the patient. And you're going to have their arm nice and relaxed. You want to make sure that you put it in the correct position above the elbow and above that antecubital crease. You're going to then take your opposite hand and you're going to palpate the radial pulse. And then you're going to start inflating the cuff. So you will inflate the cuff until the radial pulse disappears. And this is to find the upper limit. I've said this to my lab group. I've never palpated for an upper limit in the lab. I mean, in real life, in the clinic. And I've taken plenty of blood pressures. And you might be thinking, well, the blood pressure is the nurse's or the MA's job. Why do I have to learn how to do it? Well, there's been times when I've had to check my own blood pressures on my own patients when my MA was out to lunch and I was seeing patients in the clinic. On medical mission trips, I had to take my own vital signs. And there's been times when a patient has a markedly elevated blood pressure and I've had to check it myself. So definitely want to know how to do this. All right, so we've palpated for the upper limit. We're going to pump up the cuff, feel for when the pulse disappears. When that disappears, that's our upper limit. We're going to want to add 30 millimeters of mercury to that. And that will be where we pump up the cuff to when we do the actual blood pressure. After we test for the upper limit, we're going to release all the air in the cuff and let the arm rest for a second. This is where I like to palpate for the brachial pulse. So I palpate for the brachial pulse, and once I find it, I put my stethoscope in my ears and make sure that you put your stethoscope in correctly. The earpieces should be facing your patient. There's a curve to it. The curve faces your patient, not yourself. Put your stethoscope in, place your stethoscope where you felt that brachial pulse, and usually they recommend here to use the bell of the stethoscope. Now, I've never used the bell in real life, but they say because it's a low pitch sound that the bell is the best way to hear it. For my lab group, I let them know that I'm okay with them using either the bell or the diaphragm. So we're going to put that there. Then we're going to have them start pumping up. So you want to pump. You want to pump up to that upper limit that you calculated earlier. And then you want to gently release the air out. You want to release it just slow enough so that your needle starts falling at a nice slow pace. You don't want to release it too fast because then you can't accurately tell when it starts and stops. But you don't want to do it too slow either because then the needle's not moving and then you're going to have a tough time deflating and you might get some venous congestion. So it requires some practice and some skill. I definitely recommend that you get this down well. So you have the stethoscope there. You're listening for sounds. It's very low pitch, kind of sounds like a heartbeat. And so when you first start hearing the sounds, that's your systolic blood pressure, the top number of your blood pressure. You're going to let it keep going. And when you stop hearing those sounds, that's going to be your diastolic blood pressure, the bottom number of your blood pressure. Okay. So that's kind of how I do it. What I have for you here is actually what you're listening for on a blood pressure. So I just took a blood pressure, I listened with my stethoscope, and I recorded that so you can know what exactly you're listening for. So let's go ahead and take a listen to that now. All right, so that was kind of a little hard to hear, but that's what you're listening for. You're listening for these little beats that are kind of low pitched. You're listening for them to start, and then you're listening for them to stop, and you're correlating that with what you're seeing on the dial of your blood pressure cuff. All right, moving on. So the last couple of vital signs that we don't assess for in this practical are temperature and pain. Temperature, again, we just stick a thermometer in and we take a reading. And pain is more subjective. It's part of the objective part of our exam, but it is pretty subjective. So just know that that is another vital sign that we assess for. We also look at pulse oximetry and the ins and outs, meaning how much the patient is taking in, how much they're peeing, especially when they're inpatient. All right. So that is the general survey and the and the vital signs. That is the majority of the first page of our practical examination. So let's look at the page one more time and take a look at that. All right, so we've introduced ourselves to the patient. We've done the general survey. We have done the vital signs. And next up is the skin. But before we get there, let's watch a quick demonstration of the vital signs.
All right, now we're going to move on to take some vital signs, okay? So I'm just going to start by checking your pulse. All right, let me just take this up here. Just relax. Good. Okay, the pulse was 64, regular, and the pulses were equal bilaterally. Respirations were at 14, regular, non-labored, with a normal pattern, depth, and effort. All right, now we're going to move on to checking your blood pressure. We're going to use the left arm over here. Okay, we're going to start by checking the upper limit. So I'm just going to feel your pulse here while I tighten it up. You're going to feel some squeezing on your arm a little bit, okay? All right, found your upper limit. All right, I'm going to let that rest for just a second. I'm going to check your pulse here. Good, you got your brachial pulse. Now we're going to check your blood pressure. So let's go ahead and rest your arm on mine just to... There you go. All right. All right, your pulse is 98/50. Do you usually run a little low?
Yes.
All right. Okay, and next we're going to move on to the skin exam.
All right, now let's move on to the skin examination. So the skin exam is, I like to tell my students that the skin exam is neither here nor there, meaning that whenever I have a patient with a skin chief complaint, I usually go straight to that area. If it's a diffuse rash, I'm going to look all over. If it's like a cellulitis in one spot, I'm going to that spot. I might compare temperature to the other side. But very rarely am I doing like a head and this, just checking the skin. And then the opposite of that is like, let's say I'm working in a dermatology clinic and I'm doing a very thorough skin exam. I'm going to do a way more thorough skin exam than what we're doing on this practical. So that's what I mean when I say that the skin exam is neither here nor there, meaning it's not something that I would do on a quick patient with a rash, and it's not something I would do for someone that I need to look in every nook and cranny of the body. If I was doing a derm exam in a derm clinic, I would look on the scalp, every little bit of the body, behind the ears, in the ears, under the nails, between the buttocks, between the toes. I'm gonna look way more than what we're doing here. So that being said, just get good at doing what we expect for you on this practical exam. So for checking the temperature, just like mom did when you were a kid, you want to use the back of your hand and you're going to touch. You also, if you have two of something, like two limbs, you want to compare both sides. So usually what I recommend for my students on testing the skin for all these different things is doing the exposed surfaces. So usually the forehead, The arms will be uncovered and the legs will be uncovered. So that's usually where I recommend doing these different tests. For the temperature, I'm going to use the back of my hand to test the different areas and compare bilaterally. While I start this exam, I'm going to ask the patient to let me know if they've noticed or had any changes in any lesions or moles or the color of their skin. And I'm going to be continuing my exam as I ask them that question, and that will cover the lesions, if any, and the color of the skin. And so I'm going to ask them about that. Next up is texture. So texture, you're feeling for like dry, bumpiness, smoothness of the skin, and you're going to use the pads of your fingers for that, the pads. And so for the texture, and I like to pair up texture and moisture, because I think you use the same part of your hands. You're just going to feel, and don't just do this. I mean, you're actually feeling for the texture, right? You're feeling texture, feeling for any lumpy bumpies, and you're also checking for the moisture of the skin. Differences in moisture could be like diaphoresis or dryness, right? Now you'll notice here that they also ask you to assess for the moisture of the mucous membranes. My recommendation, unless you're 100% gung-ho to do it here, is to save this looking at mucous membranes when you're looking inside the patient's mouth later on. And that's so that you don't have to get your pen light out and do it here and then. It's kind of a waste of time. It's not as efficient. But if you're like, if I don't do it now, I'll forget it, just do it here. Next up, the color. So I usually ask the patient if they've noticed any change in the color of their skin or their nails. And then I start looking at the nails. So I have the patient kind of fan their hands out like this. And I look at the nails. And I also check for capillary refill. For capillary refill, you're going to want to pinch the tip of the fingers, and you want to look for the flow of blood back. So you'll pinch it, it'll blanch, and then the blood should come back within 2 seconds. Okay. And that's it. That's essentially the entire skin exam that we have here. And you want to check every single nail when you're doing the capillary refill. Okay. So now let's take a look at a demonstration of the skin exam.
All right, Aisa, we're going to move on to doing your skin exam, okay? I'm just going to touch in a few parts on your skin and feel for some different things, okay? So we're going to start with the temperature. Have you noticed any changes in your skin at all? Any changes in the color?
No.
Any changes in the texture of the skin? Any abnormal new lesions, moles, anything new?
No.
Okay. And any color change? You said no, right?
No.
Okay. So I'm just feeling for texture, the moisture of the skin. I'm going to go ahead and pinch the top of your hand, okay? So just gentle. Just checking to make sure you're well hydrated. And then we're going to take a look at the skin and the nails, okay? So I'm just going to look, and I see that they're painted here, but we would be checking here for the refill, capillary refill. Same thing here. All right, and I'm just going to look at the moisture of your mouth. If you could just open up for me, please. Very good. Okay. So if we notice that our patient has nail polish in place, another place that we can check for capillary refill is on the side of the nail, where you can look along the edge, or you can look at the fingertips themselves for capillary refill, so you can see that you have good capillary refill here.
All right, well, that concludes the first page of the patient physical exam for your practical examination. I think the first page is one that students should get really, really familiar with, because this is where you're starting one of the most challenging practicals that you will do in your PA school, because it's so much to remember. It's a 40-minute practical examination. It's just you, your instructor, and your simulated patient. So my advice is to get this down so where it feels like you're riding a bike. Like you don't even have to think about it. It just starts flowing out. Because as soon as you knock on that door and you start this practical, your adrenaline's going to kick in. You're going to feel all this rush of, high anxiety. And if you got this down, if you've practiced this enough, this should just flow out. And that way, as your adrenaline starts coming down, then you're done with the first page and you can start focusing on the exam moving forward. Every single week when you turn in a video, you will be doing this page as well. So it's cumulative. You add it on the next time, you add it on to the next time. So by the time you're done, you should be really, really good at this. And that's it. So if you have any questions about any of the things I talked about or demonstrated, please comment below and I'll be happy to answer those for you. If you have any suggestions for your peers about how you do something, or an easier way that you've figured out, please by all means share it. Sharing is caring. And I will see you in the next video where we will talk about page 2 on the rubric. I'll see you soon.